we were asked by the Connecticut Citizens, you're going to have to help me.
Action Group.
Yeah, the Connecticut Citizens Action Group to see if we could have Kevin Limbo, who's the controller of the state of Connecticut, come and talk about a possible public health insurance program option with this, for Connecticut small businesses. Right now, they're presenting it to the legislature. You know, if you're a small business owner, you're probably like us. You have a little bit of it's very difficult to carry the premiums and carry all the costs of running a business in Connecticut. So Mr. Limbo is going to talk about the possibility of having a public option.
Thank you. Good evening, everyone, or good afternoon, or however you define 10 after 6. It feels like the middle of the day right now. I left the Capitol and left my staff in negotiation with the governor's office and the legislature on this issue. So I want to say at the outset, anything I say was true when I left the Capitol. And hopefully will still be true, or we will have made forward progress by the time I get back. So I appreciate the time. There's a bill before the legislature. There are two, but I'll focus on one. Its number is 7267. It's a House bill. And the bill is meant to address an issue that is really incredibly difficult for small employers around the state, and that is how to afford health insurance. And I should, by background, say, as the comptroller, I report out to all of you on the first of the month on where we are in the budget, but I also buy healthcare for 250,000 people. I pay out pension benefits for 50,000 people. But on the healthcare side, we've done a lot of good, smart, sort of forward-thinking things on how we deliver this benefit in a better way. And that's great, because we're saving $30 million for taxpayers, $80 million for taxpayers, 180 just last year, year over year. But if I keep that within the confines of the office, that's great for the plan, but what does it mean for everybody else beyond it brings some tax relief, which is an important thing, obviously. But when you poke a legislator or governors going back for decades or policymakers at the Capitol and you say, tell me something about small businesses, they'll say something like, small business is the engine of our economy. Right? Or some variation on that theme. But if you follow up and say, okay, so what the heck have you done about that? They'll say something like, well, we have a very sophisticated economic development plan where I pick this pizza joint over that pizza joint, and then and if you're the recipient of a $10,000 grant from DECD or some backstopping on financing, that's great and helpful. But when you think about Connecticut and its need and how we get all of our largely untapped sometime capacity to launch, you need to pull back from the winners and losers thing and think about broad-based economic development theory, and that's about make sure you have an educated workforce, make sure people can move people, product, and information easily, make sure that the infrastructure's in place to do that. If you do those things and then let business do what business does and have government do what government does, then you get closer to the sweet spot of how you get that growth to really move. So I'm buying healthcare and I think we're doing it pretty well, but what can we do to make a difference for small businesses beyond that picking winners and losers? A way to do that is to try to help with your balance sheet, right? If you're trying to get coverage for you and your family, or you have employees that you're trying to sponsor coverage for, it's a challenge, and we all know that. 25% fewer employees of small businesses who had coverage a decade ago still have coverage today. This is a failing market, not just because I said so, but by any economic analysis, it's a failing market. There are fewer and fewer competitors in the market. The pool of people is getting sicker and sicker because the only ones who are hanging on are those who can't do without it. And as a result, premiums keep escalating. So a decade ago, we took a look at this and said, well, what could we do to make a difference? And at the time, the private carriers said, please don't do anything, right? Government has no business in this. Stay out of it. We'll do better. Well, fast forward, I'd like to say things haven't changed, but they have, and they haven't changed for the better. So 7267 says, one way or another, the state has to help disrupt this market. For a decade, I've been waiting for a private entity, a private carrier to come in and disrupt that, put downward pressure on pricing, bringing everyone else hopefully down. That hasn't occurred. So if not that, then what? We could sit around waiting for something positive to happen, keep doing the same thing over and over again, but that's the definition of something, and we all know what that is. So if a private entity is not going to disrupt this, then I think government has a responsibility to try to encourage other participation and disrupt the space. So the plan in 7267 is to bring small businesses as an option into a plan that would be designed by my office in a full risk-sharing relationship with the state employee plan. Not at the state employee benefit design, because we know that's not affordable for most people. We would have bronze, silver, gold, platinum sort of choices. We would be underwritten based on geography and the limited underwriting criteria. But you would get and see an immediate price relief, because what I don't have and is present in the private market is a C-suite with a lot of big salaries, stockholders who are waiting, for me to pay off. We do things on a 2% admin versus 18 in the private market. So I can get to 15% savings without trying very hard. And when I look at all the other things we're doing around controlling the cost of pharmaceutical drugs, making sure our chronically ill people get access to care closer, faster, at a time when they need it, that people get simple things done like their physicals, their colonoscopies, their mammograms, all of that has led in our plan to cost trends that have been anywhere from 0 to the highest has been this year, it's been 8.4. But when I go to Stanley Black & Decker and I say, I've got a medical trend this year of 8.4, they'd give their eye teeth for 8.4. So the plan would allow folks to come in. My hope is that if we get a product in the market, it would put that downward pressure on pricing. Those that still want to compete would lower their prices and compete, and we would change the dynamic. If we do nothing, I think what you'll see is a continual shrinkage of that group. It will get sicker and sicker, the market will fail, and the carriers will pull out. And that will leave a rather sick group of people at the bottom of that barrel turning back to state government and asking, what should we do from here? I would like to say there had been a private solution, but it's just not happening. Second phase of this would have the comptroller, my office, and my staff go out to bid for a blanket policy for individuals who are not business owners to let them pay in, to use that 250,000 lives that we have, the $1.5 billion I spend in healthcare, and leverage it for the benefit of others. So we're in active negotiation, as I said, with the governor's office and with the legislature. There's a lot of pushback. We joke that the flying monkeys have been released at the Capitol. What that means is when they bring outside lobbyists in to help the inside lobbyists sort of like fight against the thing. But I think the battle lines are clear, and a negotiated settlement is possible. I will know that probably after we're all in bed tonight, but at some point tonight we'll know the answer to that. If it goes well, we will have a press conference tomorrow with the governor and legislative leaders to announce where we are. That doesn't mean it'll necessarily pass. It just means leadership agrees, and then they have to persuade their members to vote. If this sounds like something that would be interesting to you as a business owner, if you have questions now, I'm happy to take a few before you move on in your agenda, or if I'm out of time, I'm happy to get out of your hair. But if it sounds like something that's interesting, please call your legislator. Please call your senator, and please call your state reps immediately and let them know. It doesn't have to be tonight, but within the next week, because the legislative session ends June 5th. And if we don't get it going, it's going to die on the vine, and then I don't know if and when we'll get a chance to bring it up again. So. Any quick questions for me? I've used a lot of your time, Mike.
Yeah, just wondering, from a durability standpoint, so say you do this, so effectively, government is underwriting a cost-effective structure in the insurance thing to basically undercut the private sector.
Correct.
I don't mean it in a bad way, but just it's going to cost less.
It is.
But then aren't you inevitably going to drive out the private sector? And
so
by doing so, then we just have a one monolithic insurance structure for Connecticut.
Completely understand and agree. It's a real concern, and I've said on a number of occasions, if we set a different set of rules for ourselves, for example, and just have them for ourselves and make everyone else in the private sector compete in a different way, that's going to skew that even further. If we just go in and cannibalize the existing book of business and we don't lead to an expanded group of people who get coverage, then this is a failure.
Okay.
But when I look at a couple of indicators, and again, this is going to sound like I'm anti-capitalist, and I'm not. I'm not that guy. But when I look at the medical trends, like the cost year over year of what healthcare just costs, like how much did hospital costs go up, doctor's office, that number goes, let's call it 8, 9, 10. When I look at premium increases, they're not 8, 9, 10, they're 12, 15, 18. And then finally, when I look at the net profit line, it's gone from 11 billion to 16 billion. So I would argue one of two things is going to happen. Someone's going to say, we've rung the cash register as much as we can. We've eked out every premium dollar we can out of these people. We don't really want to go any lower because, we can move on to something else. In that case, that's what they'll do. But there are companies in the small group market now that are Connecticut domiciled, they're licensed here, they're not big nationals, and they're competing hard for that small business market. These are the carriers who are like, we appreciate the shifting of the dynamic, and those are the folks who aren't necessarily going to go away. Doesn't mean that Cigna, Anthem, well, Cigna doesn't really work in this market, but Aetna may say, yeah, we're not going to do this. Well, they don't do a lot in the small group market anyway. Cigna does none except in the insured. Anthem will have a decision to make for itself. Connecticut is domiciled here, so they're going to try to make it work for themselves. So.
Another quick follow-on with that. I had my knee done like 4 years ago, and I tried to figure out what it would cost.
He's not a doctor.
I know.
I can't diagnose, or you don't want me to.
But an interesting thing is, I tried to figure out what it would cost to know what my burden was going forward, and I couldn't. I looked all over, and I really couldn't. And most of my family's in the medical field. So, do you have provisions in this insurance plan to start? I know you can't do it for everything, but as long as consumers can start shopping. Yes. With those downward pressures on things, is there a provision in this insurance thing that if you're going to be part of this as a medical group, you need to start posting what your costs are going to be so the consumer then can go out and...
To get to the savings, we're likely going to have something akin to a narrow network, meaning high quality, moderate to lower cost. Right? So people are going to know that buying in. That all of that information will be and is right now publicly available for the people that we work with. We also negotiate hospital contracts with upside downside risk. Like if you do hips really well, I want to drive people to you to do hips really well, because sometimes the place to do a hip isn't the place where you like normally would go, where your kid was born, where your father died. We all gravitate to like our parish church and that hospital. That's sort of where we go. That may not be the best place. We do a lot of work around transparency, and we have a smart shopper program. So someone who is told, for example, you need back surgery, you call up, and it would be easy to just go blindly. But if you call and say, it's been advised that I have back surgery, we say, okay, here's a list of 3 providers in your area that have high quality and moderate to lower costs. If you go there, we actually pay our folks $100 to do that, because it saves me $15,000 to send them down the street. Mm-hmm. So that makes some of my hospital friends crazy, it makes some provider groups crazy, but it's all about cost and quality, right? It's not about affection and love. This is about, yes, it's about comfort with your provider, but we have to be able to put this information out there. It's been easy for a long time to put cost data out there, but people gravitate to a high-cost provider because they somehow think high cost means better, and that is not always the case.
Yes, thank you.
The past 8 years was your study period. There was a lot going on with healthcare in the last 8 years.
Yeah.
Right, and it's still changing.
Still changing.
So it's hard to say that it might not continue changing. Is this going to adhere to Obamacare, or is Obamacare in place here? And is the fact that mandate's not there affecting the pool and stuff?
So all of that, you're right. It's a very dynamic space right now. And when I talk about our health enhancement program, for example, which is a value-based insurance design, I often attribute our control of medical trend to that and some other things we've done around controlling costs. But you're right, there's a lot going out in the world, some of it good and some of it not so great. The vertical integration of the healthcare system, where hospitals buy labs, buy doctors, so they own the whole sort of silo, looks like it could mean good coordination of care, right, at its best. At its worst, it means layering on facility fees for things that were never there before, driving up costs, self-dealing, all of that stuff that we know we need to watch out for. The future of the Affordable Care Act or the exchanges, I think that will continue to move along. There's lots of debate up at the Capitol right now about what do you do when you sort of lose that mandate piece and people now can go out and not get coverage. Well, what does that mean to everybody who's left behind? Generally, they tend to be sort of sicker and they're buying coverage because they have to, driving up the cost. This gets sort of misconstrued sometimes, but health insurance is social insurance. And I don't mean social benefit. I mean, it means that you're younger than I am, you're probably going to pay a little bit for me in your premium. But that means at some point, somebody younger than you is going to pay for you. Like, we all sort of equal this out. And if we get to a point where I don't need birth control, or I don't drive on that road, so I shouldn't have to pay taxes to do that, then you start to really, just leave behind a very vulnerable and narrow group of folks. So we've been told for a long time that skin in the game, right? If we just give people good information, they'll make rational choices. Maybe, maybe not. I know a lot about the healthcare system after 30 years of analyzing all of this stuff, but when I'm the patient in that stupid gown sitting on the table and he says, I need you to go down the hall and get this thing done, I'm like, okay, because we become a patient in that moment. And so we need systems that support good decision making, but not force that decision on another, but at least give them the guidelines. So yes, a lot going on. This would be disruptive, without a doubt. Yeah.
We've all seen the frenzy of activity with one hospital competing against another hospital, pop-up hospitals and clinics, and every corner, it's almost like a CVS in every corner. I'm seeing more and more and more of this. Now, it seems to me, my sense is that there could be some kind of consolidation, encourage some consolidation. There might be some savings in that, like anything else. The duplication of services with all of these facilities has to add a burden. You would think that they'd be competitive and the price would come down. I don't think that's happening. I think the prices are remaining the same. But we could save money if they were to consolidate instead of competing.
Right. Yes. So we have a certificate of need process in Connecticut that you're supposed to file before you can open a new radiology suite or a new cardiac cath lab or whatever the thing is. The thing is so darn broken that those of us who really saw it as a good tool for coordinating just what you're talking about wondered for a while if you might not want to just pull it all up and just let the sort of market do what it's going to do. But you're right, then you get CVS and Walgreens, right? Then you get that going on. It has, in fact, driven up costs. I live in Guilford, on the other side of the Q Bridge. Norwalk was actually my second choice when we were leaving New York City and coming up 95 on a Sunday, like where should I live? They put in, Yale New Haven Health System put in an emergency room in Guilford at the time the Q Bridge was being constructed. Part of the way they sold it to planning and zoning in Guilford was, if you have a heart attack, we can't guarantee that we're gonna be able to get you over to the mothership, so maybe we need something here for you, which was complete crap, by the way. And so they sold it effectively, but you go in there now, and it's a very pretty suburban happening. It's well carpeted, it's well appointed, there's a nice curved coffee maker, there's a big flat screen TV, and you can probably make an appointment to go in and have your heart attack. I don't know, you can know what's going on. That's not an emergency room. In my view, an emergency room should not be pretty, right? It's where you go when you have an emergency, and we have all of these little places that have sprung up. We had a string of urgent care centers that were billing at emergency room rates, and patients were doing what they thought was the smart, responsible thing and not going to the ED, right, but going to the urgent care center, and we were still getting paid because behind the veil, behind the certification, was an emergency room, and they were billing us at those rates. So, who else is going to protect this, right? If we don't figure this out, letting it run on its own is clearly not working.
I agree.
I'm asking your professional opinion on this. I don't know where I read it. Very bad at that, but I just read somewhere that Connecticut was ranked 3rd in insurance and healthcare. Don't know.
As an employer or as just innovation?
Quality? Yeah, quality.
Quality, yeah.
So based on, obviously it's biased on the publication, you don't know where it's coming from.
Yeah, don't know.
Based on your professional opinion on your 30 years experience on this, any truth to that? 3rd, 5th, 6th, are we up there or are we?
I wouldn't know where to put the number, but generally the quality of our healthcare is actually pretty darn good. So we're lucky in that way. It doesn't come for free, right? It didn't happen by accident. And it means when bad stuff happens, we intervene, right? That we sort of put a stop to the things that have been allowed to sort of run amok in other places. Just as a side note, we were also listed recently, you probably saw this by Bloomberg, as the 4th most innovative state in the country. Now that's only a marker of things that could be, but it's about STEM education and engineering and a whole bunch of things that Connecticut tends to be a little down on itself. When we moved here, we picked Connecticut. I was like, this is actually a pretty cool, beautiful, like I liked the people, I liked the values as I understood them. You know, I want to come and bring my sort of not traditional family like up the road and live here with all of you. And then I get to Connecticut and it's like, oh God, something bad's about to happen. It's like all this, yeah, we've got challenges, there's no doubt, but folks get stuck in that, like, you know, and then we just talk down our own success and step on our own tail to the point where of course people are gonna leave, you know. Anyway.
Amen to that.
Yeah, thank you, I appreciate it. Yes, that's it.
Okay, so I remember many times when talking to people in the military, or whatever, get basically, you know, $87 a year in premium, and then we get to a family of 4, and it's just prohibitive because it's just more than everything, more than our paychecks, more than our, you know, especially small business owners, more than our mortgage and everything. And then we hear about the feds passing Obamacare and everything, and we could never understand, and it's all hearsay, I don't understand the whole industry, but we never can understand why these legislatures were voting in this big health care program that they weren't going to have. They were going to have different health care than the rest of the people who had to buy into this other health care.
Yeah.
And then the question is, when Bill Collins came and told me about you guys, the first question was, am I gonna pay the same premium as a Connecticut State employee?
No. And as I said, the benefit designs are not sellable in the small business market. And we have a parallel program for municipalities, and I have a piece of legislation this year that would give us more benefit design flexibility there. I've got 50,000 lives in the muni pool, but they're all Fairfield County lives because the cost of care here is greater than it is in the rest of the state. So they came over because it made sense for them, but it threw the whole sort of pool off a little bit by about 7 points. So we need to sort of balance that. Benefit design is going to be critical to the success of this.
So you're saying basically that the individuals be paying more because we're individual for the benefit?
Well, no. I mean, look, it really depends, right? So in individual underwriting, some of the problems with that were taken care of in the Affordable Care Act, but the exchange is actually not working for everyone, particularly those who were like at 400% of the federal poverty level to about 600%. It's like you own just enough not to qualify for subsidy, but too much, you know, to act, or too much and not enough to actually afford in the private market. So that's really got to be where the sweet spot is. As a corollary to that, there's 26,000, they call them husky parents, who were like in that band, who all got pitched off in the last couple of years. Like that's an immediate way to sort of bring folks back on. It has a price tag to it, but you pull down 50% from the federal government. So we have to do the actuarial work, right, to tell you what premium's going to be. Mm-hmm. But what you get with a plan like this is active management. And I think we liked to believe, or wanted to believe, that the commercial carriers were like running herd over costs on our behalf. But the evidence proves that they weren't, because they also didn't want to aggravate the hospital or lose the big provider group. So they knew they could just sort of calculate it into the rates and move it along to you the next time. And then 10% of you all like dropped off, and then sort of we do it again next year. My plan, they don't go away, right? The people I've got in my plan, I've got them from the time I've got them to often the time that they die as retirees. So long-term investment, managing that trend, engaging, you know, some nurse educators for disease states that really matter. That's the way we save money, is by doing it, again, smarter, but it's focused on healthcare. The financing is the secondary part of it. But it would be on the market for you to pick. You could look at it, compare it to what you've got, compare it to whatever else is out there, and say, yes, I want this, or no, I don't. So no mandate in this piece of it at all. All right, I've taken a lot of your time.
Question, just from the perspective of employment or employers, can you just shed a little bit of light on the consolidation between Yale New Haven and Columbia Presbyterian and Sloan Kettering, and is there going to be more consolidation? Is this a source of employment for people in the area?
Yeah, look, healthcare is a big employer in the state, right? There's a lot of people
growing,
who
or
work.
is it shrinking?
At this point, I would say it is still growing. It's growing in interesting, so in sometimes like super expensive ways, with less emphasis on primary care, palliative care, like close-up touch care, and more on technology and widgets, and But pull back from that for a second. When you've got the big, scary cancer diagnosis, which 70% of us are probably going to get at some point. Sorry to say, you want that good technology, the best in its class, the places to go. So, it's like balancing those two things. And I'll just say something else about employers. Not directly related to your question, though. There are smart, mostly young, with apologies to folks who are in my age band or above, folks who were trained often in Connecticut or went elsewhere and came back, and they're working sometimes in corporate environments, like chained into their cubicles, doing work even though they have this big, smart, innovative idea that they'd love to like jump out and do, but they can't, right? Because they're afraid. They got a young family, they've got a chronic disease, a pre-existing condition, whatever it is. So that innovation and that financial sort of up is lost to us because in some cases they're afraid or can't break out of that. If we can do something that sort of opens the gate on that, fourth most innovative state in the country, right? That means a lot. Secondarily, to an employer who is in a, let's say, in a supply chain to a larger employer, you know, somebody feeding into EB or somebody even feeding into some of the hospital systems or research, if they bring folks in, train them, now they've got some skills, but they have no benefits. They lose them often to the bigger employer because the benefit package is better, and then they repent. So it's rinse and repeat, right? Do it again, to the point where like they're sinking all of this investment, and then they're losing it because they can't, even if they wanted to, compete a little bit with the benefit package that a larger employer can offer them. So what I'm proposing in this is, well then, what can we do to allow small businesses to afford a benefit that would really attract and help them retain smart young folks who want to do work outside of the cubicle? I'm looking to get out of the cubicle. Okay, I've taken way more of your time than I was supposed to, I think. I really appreciate it. Again, 7267, state reps, state senators, call the governor's office. They love to get calls. You know, as a small business owner in particular, let them know, even if you have concerns.
We have Bob Duff in this town. So,
Yeah. Well, no, he's a guy on the leadership.
Call Bob Duff.
Absolutely, let Bob know. I think he's in favor, but you can ask him that yourself. Great. Thank you all.
Thank
Okay.
you.
Headed back. Thank you.
Thank you.